Welcome. My name is David Balat. I'm the director for the Right on Healthcare Initiative with the Texas Public Policy Foundation. And today we have a distinct pleasure and honor to talk with our guest, Dr. Tony Dale. There's no shortage of people that want to talk about the problems in healthcare, and there's quite a few of them. But it's rare to find groups and individuals that want to identify the solutions. You know, we try very hard to do that here. We want to focus on the solutions and how to make healthcare more affordable, more accessible, and of better quality. And I believe that that's the direction that we need to move in as a culture and a society, because complaining will only do so much, and we want to get away from that. So Dr. Tony Dale, in addition to being a good friend, is just a storied history. He studied at one of the oldest medical schools in Britain, served in the National Health Service in the United Kingdom, and started his career working in one of the oldest areas of I believe it was in London. Isn't that the area where they filmed Call the Midwife, Tony? And maybe you can talk about that here in a moment. But served there in that country and then made your way here to the United States. And we're going to talk about that here shortly. But again, welcome, Dr. Tony Dale. And thank you so much for all that you do and what you're doing now.
Well, David, thank you so much for inviting me to share on this time with you. And I appreciate the introduction. You're right. I served in the East End of London. For any of your listeners and viewers who were familiar with Call the Midwife or maybe with EastEnders, those were absolutely the streets where I had my medical practice. You mentioned the hospital, better known in Britain as Bart's Hospital, but its formal name is the Royal and Ancient Hospital of St. Bartholomew. And all of your listeners, without knowing it, have actually seen that on film. Because in Braveheart, where William Wallace was hung, drawn, and quartered, was actually right there outside the hospital wall. And there's a placard on the hospital wall saying, in this spot, William Wallace was, hung, drawn, and quartered. I think that was back in, sort of 14-something. The hospital was established in 1123. So yes, it was pretty ancient.
But Tony, so you wrote a book called The Cure for Healthcare. Again, I'll say it again, there are no shortage of books and organizations and tweets and documents and white papers that highlight the problems that we have in healthcare. But you decided to say, look, we know what those problems are. Here are some of the solutions that we can employ. In putting that spotlight on some of those solutions, are the people coming that you're coming in contact with, are they adopting some of the things that you're recommending? What is the feedback that you receive?
Okay, that's a great question. And I think my honest answer to that isn't so much that they're adopting. Actually, I was highlighting what they're doing. There has already emerged, really right across the free market medical ecosystem, some extraordinary answers that are working and that are beginning to work at scale. And you're right, very good things have been written and clear things. Professor Marty McCary's book, The Price We Pay, really peeled back the layers of the onion. But it's as if now we all know there's a problem. We have to find the answers. And what I wanted to do was highlight that real answers are out there, not theoretical ideas, but answers that are working, that are giving people much easier access, higher quality, and dramatically lower costs.
Yeah. No, I appreciate that. There's debate here in this country, and it's been ongoing, but we continue to hear it, especially now in the halls of Congress, where the focus isn't necessarily on affordability in healthcare. It's not necessarily on increasing the quality of healthcare or the doctor-patient relationship. It's on how do we become more like these countries that have socialized medicine. You've worked in them. You've been a patient in them. You have a lot of stories about what people have experienced in them, and you're seeing what's happening today. I guess I have a two-part question for you. One is, can you share a bit of your experience, and then maybe you could help me and the audience understand, why do people in this country romanticize a system that clearly doesn't work?
Well, I wish there were simple answers to some questions like this, because they're so fundamental. let me just describe a little bit of my own experience, because yes, I grew up actually out in the Far East, but went back to London for medical school in '67. I was 17 years old. Enjoyed 6 years at this distinguished sort of medical school, and then decided, my wife and I, we were married at that point, that we wanted to serve the people that we knew and loved, and why didn't we just go to the poorest part of London? Tremendous need. And so, I agreed to begin working in a practice there. So I spent the next 10 years working in a very poor area. People who are salt of the earth, loved it, loved the people. But a number of things really became clear to me during that time. So in the London Borough of Tower Hamlets, where I was at that point, which was really referred to by most people as the dustbin. That's English for the American word trash can. It was referred to as the dustbin of London because that's where you ended up when everything else had failed. 92% of the housing in that area was government housing, sort of roughly equivalent to what over here is called Section 8, I believe. And into that context with these wonderful people, I began to realize that actually government was in a Western society where there was ample opportunity, ample resource. Government was probably the biggest single cause of failure in terms of what was going on in those people's lives. Now, part of that was the welfare system. The welfare system was very easy to get into and very hard to get out of. I mean, let me give you an example. Let's pretend that the actual numbers don't matter, but let's pretend that you need $1,000 to survive, and so the government gave you $1,000 or maybe $1,100 to survive for a month. And into that context, if you then began to do some work, you might hit a cutoff incredibly quickly. Once you were earning more than $50, that might be the end of your access to certain, such as the subsidized apartment you lived in. So you might only be earning $50 extra, but all of a sudden you have a $500 extra bill that you've got to handle. And so any incentive to learn to move yourself out of the challenges that you're in is countermanded by, I guess I would call it the stupidity of how so many government programs are run. Okay, so now you come to something like the National Health Service. The pride and the envy, according to many people, of what Britain has to offer. I know that when the Olympic Games were there, all the time on the public sort of television was how wonderful our NHS is. Well, if only they talked a little bit more to the doctors who were in it. The treadmill we were on, the maybe 5 or 6 minutes max that was available most of the time to speak to a patient, the long waiting lists. And the misalignment of incentives. If I can just give you a simple example. If the patient has full control, let's call it this way, of a specific, like how the doctor serves me as the patient, but in a context where they have no responsibility. I remember being called out on house calls. Yeah, house calls. In those days, doctors still actually went out and visited their patients on the most trivial things that any doctor could have helped explain to the patient. Really needed, the patient needed to come in because a house call was going to take an hour. At least in the medical office, we'd be able to handle that probably in 5 or 10 minutes. But this was a misalignment between the use and the caliber of what the doctor wanted to bring to the situation and the patient. Now, equally misaligned is that the patient, who absolutely could afford a pack of cigarettes every day, let's call that in those days £5, they absolutely could pick up a video from Blockbuster or equivalent, in those days, that might be £5. They could manage one of those every day. But could they manage their £5 towards their copay on their prescription? No way, because they could still find ways to get it free by playing the system. There's this sort of myth that poor people somehow are not very clever. That's completely wrong. People are people. But sometimes they become incentivized and don't realize how aligning themselves with those misincentives is actually holding them back. And I could then go into all sorts of detail in terms of the actual way the medical system was run by, delays and time constraints and, how long you have to wait for certain procedures. Because there's never enough money in the government coffers to pay for something like healthcare for everybody, because healthcare is kind of a bottomless pit. People always want more and more and more, but actually you've got to get to the root sources of helping them align what they're doing so that they're moving towards health.
We were just having a discussion prior to this live stream about that. People may want more, but there's only so much that can be given. Here recently, we've seen a number of things in the NHS where they're imposing limits, and it could be a limit in the amount of time that before you could have a certain test, or it could be how you see the doctor. One of which was really appalling to me was the primary care physicians were being overrun, and the only way that they were going to be able to see a patient was they were going to aggregate patients by a diagnosis type, and they were going to see them in groups of 15 as opposed to one-on-one. How do you have a doctor-patient relationship when you're amongst a group of 14 other people? Folks that needed cataract surgery. If you could make your way with just one cataract being done, they weren't going to pay for the other. And probably, and they're all equally bad, but another was if you were of a certain age, you could no longer qualify for a hip replacement. This is not, what we want to see come from our healthcare system. And many could make the case that, well, we have that here because of the cost, but we certainly don't want to go from bad to worse when we have the opportunity to fix what we have here today.
David, I completely agree with you. And, yes, I could point out some good things about the National Health Service. For example, I never remember a patient who went into bankruptcy because of medical bills. But is that because the patient had died before, they got the treatment that they needed? No, I'm being a little bit facetious there, but, when you look at the totality of what makes like, one of the things they have right over there is that the family doctor is designed to, as it were, be the quarterback in the system. But what happens if you have a quarterback and you tie one of his hands behind his back? So maybe he has to run his practice within, these certain parameters, and unless he can demonstrate that, 85% of the people have had their, rubella vaccine or, whatever it is that might be needed, that, he's then going to get penalized. Well, that's fine if you live in a great, comfy, sort of middle-class area where everybody understands the importance of these things and they have the money and the time. What about in an environment where I was in, where even the educational standard of the average person was probably below 8th grade. So, you start looking at this stuff and you say to yourself, there have to be better answers. And the idea that the better answers are in the minds of, generally speaking, bureaucrats, or maybe above the bureaucrats, politicians, who themselves have no experience of working with patients, is unimaginable. If we're having problems with bridges falling down, we're going to find some high quality engineers to help fix it. And if we're having problems with why healthcare isn't being delivered effectively, let's engage the key people who are involved in this. Okay, well, the two key folk are really the patient with their needs and the physician and his team with some solutions. And the free market is extraordinarily capable at throwing up good solutions. So when I look back to my own work as a family doctor back in the UK, and I now compare it to what's emerging in this country through the direct primary care movement, where on a very simple membership basis, we're saying to a person, hey, half of your cup of coffee every morning on the way to work that you pick up at Starbucks. So, maybe $2.50 or something a day. If you'll allocate that to your medical care, you'll have excellent, high quality medical care from a family doctor who's deliberately limited the size of their practice to look after 500 or 600 people really well. And to be able to navigate them not only to the best doctors, but in the best way through the system where they're getting fair and transparent pricing. And just having that high quality relationship is probably going to take care of 80% of medical needs. and it would probably cut the average person's medical cost, when you look at it in global terms, in half. Just that simple thing. Now, that's a tiny little saying, let's take personal responsibility for what I describe as the oil changes. You know, we all plan for an oil change in our car. Why don't we just plan simply that we're going to live in an environment with a doctor who's helping us towards health, and I'll take care of the oil changes. And then we need to think through how we deal with the big costs. And, you know, there are great ways that are emerging. Obviously, you know, I'm very engaged in some of those that I describe in the book, so that we can radically alter the approach in such a way that people become the strongest advocate for their own healthcare.
You created a great segue into my next question, but before I ask it, I'd love the members of the audience to start submitting any questions you might have. We may have a little bit of time for a few questions for Dr. Dale before we come to a close. But Tony, you talked in the book, you talk about being a cash patient, and that's great. For a lot of people, that may be something that they can do. But you, having worked with the poorest of the poor and having a mission for that, what do we say to those that would say, well, what are you going to do for those that are indigent, that have no cash? How do they navigate in the system that we have today? Even for DPC, that is a very affordable program. What do we tell them?
Okay, well, that's a very fair question, but I'm gonna dig into your question and then perhaps expand on the answer briefly. You talked about the indigent who have no money. Okay, yes, there are some people who literally have no money, the homeless or whatever. Just like there are some people who already have some type of serious pre-existing condition. These are two different ends of a spectrum as you look at how do you start to implement the type of thing I'm describing. And I think my answer would be the real issue there is not medical care, but social policy. And have sound economic systems. So if we're looking at the 95, 98% of people who have something, whether it's only a little or whether it's they have a lot, what I'm going to describe works. If we look at the sort of 2% of people who either have nothing or for whatever reasons they didn't choose to opt into some way to take personal responsibility, and so now they find themselves with a massive medical need. You know, this is the sort of situation if you looked at your home and you say, well, I'm not going to bother to insure it, and then unfortunately there's a house fire. Okay, no insurance company is going to accept you the day after the fire so that they can pay for what you didn't plan for. You know, that's not sound economics, but it is a social issue. We better have a way to help shelter people who, have been careless with their home and have been left homeless in that sense. Obviously, that's not the usual cause of homelessness. I'm just trying to illustrate points. So I can give you good answers for the 98%. For the 2% that are the serious outliers that, yes, we have some responsibility towards a society, what I would suggest is that society, in its own compassionate ways, has come up with much better answers than the sort of government solutions of redistribution of wealth, which is pretty much what most of socialism is about, in such a way that it de-incentivizes the desire to work and to take responsibility for yourself, supposedly to help other people, but often for that not to be the end result. The end result to be what I mentioned in the part of London where I lived, where all the malalignment of incentives had bred generations of people who thought it was best to be dependent on the government rather than to take responsibility for themselves. So, you know, the context that you're sort of asking me, with people having nothing, maybe that's answered that. So let's talk about people who at least have something, even if it was just that they had Medicaid in terms of, or Social Security that was, putting some money in their pocket. Anybody in that position could put $5 a day. Okay, that's $150 in a month. That's double what it costs. So maybe they could put half that, $2.50 a day, to say, this is towards my health. And I'm going to learn how to be healthy. Now, even the poorest people, but who have some money, are fantastic consumers. Now, they may not have been taught that it's probably wiser to buy your milk at HEB than at 7-Eleven because you get a much lower price. You may have to buy, a half a gallon instead of a quart or something, but, they may not have been taught some of those simple things. That's easy to teach them. It's the same in healthcare. People are great consumers. Jamie Lagarde, our president at Sedera, our CEO at Sedera, he loves to say that Americans have a superpower. And that's to be a consumer. It seems like every American knows how to be a great consumer. They can easily learn those basic principles in healthcare when they are allowed to have access to something that's open and transparent. And that's really what myself and so many others are working on in the medical world to create an environment where it's easy for people to learn and easy for them to participate in something where they are making the choices that is best for themselves.
Yeah. Thank you very much. And you always do a great job of leading us right into the next portion of the live stream. We have our very first question from the audience. And the question is, how important is price transparency in all of this? If I may, but before I have you contribute to that, when you hear people talk about the lack of affordability in healthcare, they're saying, well, it's not just the 2 to 3%. It could be more like 40 to 50% of our society can't afford healthcare. Well, that's because healthcare is extraordinarily expensive and needlessly so. It doesn't need to be as expensive as it is. My experience being in the hospitals, and I can tell you that that's absolutely the fact. But it's also because there's so much opacity in the system. So this is a great first question. How important is the price transparency in all of this, Tony?
Okay, pricing transparency is a part of the answer. Mm-hmm. But let's put it this way. I think in law they have the concept of, please will you tell us the truth, the whole truth, and nothing but the truth. So, if you go to a hotel, on the back of your door will be what is known as the rack rate. This is the highest rate. I don't know if it's regulated by law or, the business itself determines that, but it's a rate that I guess, let's call it, they're allowed to charge. And maybe it says $500 a night for the room, but nobody ever pays $500 a night in that type of hotel. The price there is more like $100. Okay, medicine is like that throughout, except that the rack rate is so difficult to see that every part of what is published becomes, from my perspective, a lie. I'll give you a very brief example that I mentioned in the book, from one of my own medical needs, where, I went in for something very trivial, whatever, and, was in that case overnight. And the hospital bill was about $28,000 in that particular incident. But already, before it came to me, they had put a cash discount of 50% that brought it down to $14,000 in rough terms. And so, the question would be, oh, wow, isn't that awesome? No, everything about that was a lie. Okay, the 28,000 was a nonsense number, complete nonsense. When people talk about PPO discounts, this is sort of, because we've aggregated a large volume of business, they've agreed to give me, X dollar discount, but discount off what? If I get 50% discount off a fictitious price to start with, and if I look up the price for what happened to me, and see what they're willing to receive from the government, and to still be quite happy, most hospitals that maybe 50% of their work comes from the government, they seem to be doing fine. They're all built in marble and all brand new, and all have sort of skyscrapers around them, building more. So they're obviously finding money from somewhere. And maybe on that procedure for me, maybe the price was $1,500 that the government would have paid. And yet they were trying to gouge me out of 10 times that as a cash payer and claiming that that was half the money off. Okay, we're living in a system that is broadcasting a lie. And so into that context, transparency on its own is not enough. You have to know if they're telling the truth in transparency. And what will deal with that is free market, because let them charge $15,000 if this free market surgery center next door is taking care of that at $6,000. The hospital will go out of business. And someone says to me, well, what about then if there are two free market surgery centers and one of them is charging 6 and one is charging 4? Fine, then you as the consumer decide where you're getting the best quality and the best value. You decide what you want to do. But let's engage people in their healthcare in an environment where we see the truth and aren't trying to make decisions based around lies.
Thank you very much. One of the things that I really enjoyed about your book, Tony, is I asked you to sign it, but what you did is you put a sticker on there. You put a sticker and then you signed it. At first, I thought, well, that he got out of inscribing my book, but I really have taken a lot of pleasure from reading this. It looks like a prescription, and it says, David, the cure for healthcare: get engaged, join the mission, repeat as desired. Tony D. Tony, the reason I bring that up is because I absolutely love that, but it falls in line with this last question that we have from the audience. What can the everyday person do to help in the fight to improve America's healthcare system?
Oh, I love that question. That's a great question. The first thing is get engaged. It takes willingness to engage for a system to change. So, 10 years ago, 2 guys standing in the rain in Paris, unable to flag down a taxi, began to say, surely there's a better way to do this. And they came up with the idea of Uber. I'm sure they hit all sorts of, challenges in the process of coming up with that idea. But then they needed people to take action. And, they stepped out there, and I'm sure that, whether it was the Taxi Drivers Association or whatever, the city council, they were fought at every place. But they had a great idea, and people had an opportunity to try it. And the idea and the experience of trying it was so good that it rapidly spread. We're in a context where I would say exactly the same thing. If you take someone like Karis Rosen, the owner of the Rosen Hotels and Resorts in Orlando, he, as a businessman 20 years ago, said, this insurance model is not working for me. And he called in the insurance executives, with his large number of employees, and he said, this isn't working. And they said, well, unfortunately, we can't change any of this. This is just the way it is. And he said, well, no, it's not. They said, well, what do you mean? He said, well, I can fire you. But he had the courage not just to fire them, but to fire the system. He opened one of the first sort of on-site clinics, roughly equivalent to what anyone can find today through, a DPC practice or whatever it might be. And so into that context, by being willing to take on the system, okay, all of us, by getting engaged, can change. We can change for ourselves. And if we have the responsibility or the position, if there are CEOs or others who are listening to this, they can actually use the authority they have to help their employees and all sorts of others that they influence to become a part of what is already transforming the system.
Tony, it's been a real pleasure to have you on. Thank you for coming. Thank you for your experience, the stories that you're telling in this book that's badly needed. And I would encourage everybody to pick it up if you could. And I echo what you say in getting engaged. I think it's extremely important. People have gotten to the point where they've thrown their hands up and they don't feel like they can make a difference. And if I didn't think that was the case, I wouldn't be doing what I do. So thank you for your time and talent and the effort that you put behind it all.
Thank you so much. It's been a pleasure sharing with you.
And thank you to our audience members. Thank you for your time, your attention, your willingness to listen to us today, and for the questions that you've offered. We're thankful that this is something that you want to be engaged in, and please let us know how we can aid you in that effort.